women's health. And I thought I'd start off just by giving you a little bit of information about who is this mysterious Dr. Edward Holme, and why on earth are we having a meeting in his name. So Edward Holme was a leader in the medical profession, based in Manchester, actually. He was born in Kendal in 1770. And his father was a farmer, so he wasn't particularly going to go to any prestigious university, but he managed to work his way up. He studied at the universities of Göttingen and Edinburgh, and then he did his MD in Leiden, all about lymphatic system. And if you want to read it, it's in Latin, it's in the Wellcome collection. Anyway, he was one of the founders of the Portico Library, and a president for 28 years. And he also co-founded what became the British Medical Association. And he basically had a huge library when he died. He basically died unmarried in 1847 in Manchester, leaving property, which was at the time £50,000, which is equivalent to around about 8.6 million. Which was then sold, and all of it was donated to UCL. Now, I don't know why it went to UCL, but I suspect it was because there were not many medical schools at the time, and University College London was only 21 years old, so had just left being a teenager and was becoming an adult institution. And so he left all his books to the medical department at UCL, and also bequeathed some money to celebrate and to basically educate people. And so that's why we have the Edward Holme Lecture today. And there were lots of speakers in the 1970s and 1980s, and then it went a bit quiet. And then when I took over as director, we decided to resurrect it. And we had our renewed lecture 2 years ago, which was from Professor Xianglin Tan, all about female fertility preservation. So I think Edward Holme will be very happy to learn all about climate change, because, of course, he was in Manchester in the Industrial Revolution. At the time, there would have been around about 100 mills in Manchester. Cottonopolis, it was called. He would have known that there was lots of industrial disease. He might even have started to see environmental change. So that really ties in nicely with our speaker this evening, Jane Hirst, who's chair of Global Women's Health at Imperial College London, and she's Director of Women's Health at the George Institute for Global Health, and she's also a consultant obstetrician. And she completed her medical degree and training in obstetrics and gynaecology in Australia. She did her PhD in Vietnam, developing work on diabetes and realizing there was a high prevalence of the condition, and highlighting barriers to care in low resource settings. She's gone on to co-develop the first international fetal and newborn growth standards, something called Intergrowth that we use at UCLH, and Smart Health Pregnancy Programme in rural India, which is a community co-developed initiative looking at how we can improve detection, referral and management of women with high-risk pregnancies, and particularly following up. In response to the growing threat to climate change, she co-leads the Wellcome-funded Heat in Pregnancy India programme, which looks at the effect of extreme heat on pregnant women. And in 2024, she was profiled in the Lancet as a champion of global women's health. So we look forward to her talk this evening, protecting pregnant women and babies from extreme heat in a warming panel. Thank you, Jane.
Okay, hello. Right, seems to be working. So thank you for that introduction, Anna, and thank you for coming along this evening. And thank you for those of you who are joining online. What I would like to share with you all this evening is a sort of an outline of an emerging and new and increasingly important area of perinatal women's health and child health, which is actually around the effects of climate change and how we all know we're living in a planet that is changing, that is warming, that is more polluted, how these things may threaten some of the hard-fought gains which we have achieved across maternal and newborn and child health. So Antonio Guterres back in 2023 came out with this statement that the era of global warming has ended, the era of global boiling has arrived. And I think this may sound, quite extreme, but when we look at, what is happening in terms of our temperature change and the global air temperature change from the back in the mid 1850s to today, there's a clear trajectory of this graph. I don't think, anyone would question that we're not getting warmer. And as most of us have heard, last year was the first year to surpass that 1.5 degrees Celsius threshold, which was set by the Paris COP meeting, the Intergovernmental Panel on Climate Change. And whilst we need to have sort of 10 sustained years to say we've truly passed that mark, I think, as we've all seen this year, it hasn't got any cooler. And I think the trend is that things are going to get hotter. So we had 4 heat waves this year in the UK. Western Europe and the Mediterranean region had severe heat waves with wildfires and excessive deaths noted throughout that period. But what I want to focus on today is not just sort of close to home. What does it mean if we suddenly go from, a summer of 24 degrees to 30 degrees in London? It's actually thinking about what's happening in the rest of the world. And the world is not warming at an even pace. And actually the tropical regions, and particularly across Asia, we find are warming at twice the speed of the rest of the world. So this is a particularly urgent problem. And I guess to anchor where we're coming from today is, I'm, as Anna mentioned, I'm a professor of women's health. And so it's just to realize that the effects of climate change are not gender neutral across the board. And when I say gender neutral, what I'm talking about here is the roles which society put on us, as well as sex differences, which can be there. So it's sex and gender, which can differ. And this can be direct effects. And I'm going to be talking quite a bit more about the effects in pregnancy. And there are also other effects on reproductive health, which clearly disadvantage women in that circumstance. Although when we think of some of the microplastics and pollutants, there may be influences also on men's reproductive health. But when we think about things like mental health, we know that sadly more men take their own lives from suicide during extreme weather events such as heat waves, droughts, and other extreme events, whilst women are more likely to suffer climate anxiety, which particularly in younger women can be extremely debilitating in their lives. We also know that during heat events, there is an excess of deaths, and that excess of deaths is actually amongst females. So men and women both die. Why would that be? Well, we know that women live longer than men, but we live longer with more multimorbidity and comorbidities. So people who have heart disease, people who have kidney disease, people who have poor lungs function are all particularly susceptible to death from heat stroke. And in addition to that, women who are suffering from cognitive decline or dementia, which as we know is more common in women, may not be able to self-regulate their own body temperature as effectively during these extreme events. Probably, though, what's going to, really change the world and change how, the pressures that are on every country are the indirect effects of climate change. And this is, again, a gender difference. So when we look at migration and changes in livelihoods, we know that younger men are far more able economically and socially to be able to get up and move somewhere else if the conditions are tough. We also know that health system access can, particularly during extreme events, affect women and pregnant women. So I remember years ago when there was the tsunami in Banda Aceh, speaking with one of the army medics from Australia who was on one of the first surgical divisions to actually land after the tsunami. And they got in about 3 days after it had hit. And he said, basically, anyone who was badly injured had already died. But what they ended up doing in their army hospital was cesarean sections because women needed access to safe birth and birthing facilities. So climate can certainly disrupt health system access. Gender-based violence goes up, sadly, during extreme heat and other climate events. And then there's the other things which can affect, such as differences in nutrition. And as we've all heard recently about changes in vector-borne disease with diseases such as Zika, malaria, dengue, reaching areas where they've never been seen before, including in Europe. So what I'm going to talk about today is I'm going to focus, as I say, on the issues specific to pregnant women and their babies. So I'm going to outline what we know about the risks, and I'm going to take a particularly global focus here, so relevant to us here in the UK, but particularly for people living in low and middle income countries. Then I'm going to think about, well, why would pregnant women be at risk, and talk about what we know and what we hypothesize about what is actually happening. and then talk about our program of work, which Anna mentioned that I co-lead with Professor Shinjini Bhatnagar, who is a professor of child health in India, and talk about the work we're doing to try and answer some of those key uncertainties. And then finally come round to actually, well, so what? What do we do about it? Because I mean, this is the thing as clinicians and as policymakers and as public health professionals, we really want to know about. So thinking firstly about what are the risks of heat in pregnancy, I want to start by talking about some of the work which underpinned our Heat in Pregnancy India project. And this comes from my colleagues at Sri Ramachandra Institute of Higher Education and Research in Chennai. So the lady sitting in the front of the picture here in the pink sari is Professor Vidya Venugopal, and she's a professor of occupational hygiene. So she's very interested in work exposures, particularly around environmental exposures. And the lady which I've circled in green there was her PhD student, who's now Dr. Rekha. And Rekha's PhD project actually looked to see about the effects of occupational heat exposure on pregnant women in Tamil Nadu state in India. So she recruited 800 women in first trimester of pregnancy. 400-ish of those women were recruited because they had high heat occupation exposure, like they worked outside in the fields, they might work in a brick kiln factory or a bakery or somewhere else where they were going to be outside a lot, during the summer months. And then the other half of them were recruited from occupations that were likely to be less heat exposed. So this might be people who are working as healthcare assistants indoors, or domestic workers, or in schools, those sort of occupations. And she followed all these women through their pregnancies and to birth, and looked to see were there any differences in the outcomes as listed here on the slide. And how did she decide, who, other than thinking what would be a hot job and what would be a cool job, is there actually a scientific way that we can decide who is heat exposed and who is not heat exposed? And what she and her colleagues ended up doing was looking at the occupational health exposure limits. And they talk about sort of safe threshold limits of this wet bulb globe temperature concept, 27.5 degrees for heavy work and 28 degrees for moderate work. So for those of you who don't work in the climate space, wet bulb globe temperature is more than just air temperature. It takes into account humidity, solar radiation, and wind speed as well. And it gives a far better assessment of the physiological conditions that people are facing, rather than just the atmospheric temperature. So it's quite important. But what's also important to know about these thresholds is that they actually come from the United States back in, I think, the 60s and 70s, from young, fit male army recruits when they sort of tested them out in the heat, and then they worked out these were the thresholds. So whether these thresholds are appropriate for pregnant women who are anemic and, underweight and things working in the fields in Tamil Nadu is another question, but they were the only thing we had available at this point in time. So, and to cut a sort of a longer story short, you can read her paper if you want the full details. After adjustment for potential confounders and things, what Rekha and colleagues found was there was a pretty striking difference in poor outcomes between the women who were heat exposed through their occupation and those who were unexposed. And you can see here sort of a doubling of a composite outcome of either having a miscarriage, low birth weight baby, preterm birth, or stillbirth. These are all major things that as obstetrics and gynecology professionals, we're trying to work to prevent all the time. And if we took miscarriage alone, that was actually 3 times the risk in the people who were heat exposed. And we can think about, we've known for a long time that, women who have high temperatures in the first trimester have an increased risk of congenital malformations, neural tube defects, these things. But, this is kind of, emerging evidence to say that, it could be weather conditions which are actually also increasing some of those risks. And so in this study population, this is not the general population, but the study population, for every 100 pregnancies or women who were pregnant in this population, an additional 8 babies died, were born too small, or born too soon, compared to the women who weren't exposed to heat. So this is pretty striking. And if this were to play out at a population level as the planet gets hotter, you can see how this could have a really major effect. And this work was picked up by the BBC, and there was a sort of a nice little documentary where we heard some stories from the women themselves about what it was like to work and when you're pregnant under those heat conditions. And as you can see on their sort of website, they highlighted some of those major findings. But what do we know sort of outside the sort of this Indian study? It's one study. What have other people found? Is that what is this association and what are the risks involved? Well, luckily for me, I haven't had to go and, you know, trawl through a lot more literature here because Matthew Chersich's group, led by Lacou et al., published in Nature Medicine last year a massive systematic review exactly looking at this topic. So they found 198 observational studies in this area. And what they found was when they sort of pooled those studies, there was a clear, you know, increase in risk of preterm birth across all the studies. And the graph that I've shown, or the figure here, shows what the studies were actually looking at. So you can see most studies actually look at preterm birth. That's the most common thing people have examined. And you can see from the sort of burgundy colored lines that most of the studies have found a harmful association as well. Not all of them. A few have found negative or a protective association, but by far and away, harm seems to be the major color coming out here. And you can see that, you know, going down from there, the other outcomes which have been looked at. What's important to note here and what's different from Raker's study is these studies are all based on probably satellite or weather station data of what the, you know, sort of weather was like during the time women were pregnant, and then looking at big pregnancy databases like we might have in the NHS or somewhere to see if there are any differences in rates of these outcomes associated with weather changes, basically. So we don't know whether the individual women themselves were actually exposed to the weather, because as we all know, if you sit in a climate controlled environment, you know, you're not going to have probably the same effects as someone who's working out in a field. So it's an association at that sort of ecological level, but we still need to know more details. The other big caveat of this research is where it comes from. And this is, again, from that same paper. You can see here the dark blue colors are pretty clearly bunched, either in the US or in China, with sort of the temperate zones and in you know, Australia, a few studies there, not a lot from Europe, and really very small numbers from Africa, Asia, Southeast Asia, and the sort of equatorial zone, which arguably are the locations that are experiencing the worst changes. Our group have just published actually in the last week a sort of updated review just looking at these issues for women from low and middle income countries. So taking away that sort of global picture, thinking could there be sort of, you know, more severe effects, particularly for people living in temperate zones. And what we found is actually when you take out all the high income countries, there's not a lot of studies left, unfortunately, and a lot do come from China still. But interestingly, our group have sort of shown that actually it seems to be exposure in the first trimester and the third trimester from this observational data, which seems to show a significant association. So for those not familiar with these sort of forest plot things, if the sort of diamondy blob, which is the blue bit I've circled here, is sort of not crossing the one line, it normally means that there is a positive association. And if it's less than the one line, it would be a protective association. But again, not large numbers of studies there and the same limitations. Okay, so, well, if we think, okay, there is probably something going on here, why is there something going on? And that's what I want to look at next. So we're going to look at sort of why would pregnant women be at particular risk? And my good colleague, Anna Burnell, who has been working for a number of years with the London School of Hygiene and Tropical Medicine unit out in the Gambia, you know, did a really great article on this in BJOG a couple of years ago. So I point you to look this up. But basically, we know that during pregnancy, there are obviously a lot of physiological changes which happen to accommodate the growing fetus inside. But there are also, we know that there are some things that would increase heat production during pregnancy, i.e. the baby is going to be making some heat, so fetal heat production, and the basal metabolic rate goes up to cope with, you know, the increased demands of having a growing person inside you. There's also changes in surface and to area volume ratio, which can affect, you know, how much surface you've got to sweat and to give off heat passively. But nature has actually built in some stopgaps. So pregnant women are actually not unduly affected by being exposed to heat. So these sort of things are our core body temperature lowers slightly. We have a lower threshold to initiate sweating, which is one of the most effective ways we can self-regulate and cool up to a certain degree. there's an increased ability for the tissues of the body to absorb heat. So we call that specific heat capacity, and increased plasma blood volume and skin blood flow, which also will be able to dissipate some heat. So actually the heat chamber studies, which have looked at how pregnant women are adapting physiologically to heat, tend to say that they're not actually that much worse than people who are not pregnant. But leaving that aside, there's still obviously something else going on. And what else could be going on, particularly affecting the baby? So the woman is probably okay, but what's happening to the baby? And again, Anna's group, we've published this sort of schematic of a hypothesized sort of number of different pathways that could be going on. And I say these are hypothesized because this is what the current research is looking at. So, and I mean, one obvious thing would be, well, if all that blood flow is going to the skin to dissipate heat, does that mean less blood flow is going to the baby and the womb? And could it be just a reduction in circulation to the womb, which is causing this? So, hypertension, and vasoconstriction, changing blood flow to the placental bed, maybe. Could it also be that, being actually raising core body temperature through being exposed to environmental heat is actually setting off a cascade of, biochemical events? For example, are there changes in heat shock proteins? Are there changes in immune factors, in cytokines? Is there sort of inappropriate release of oxytocin, which might be, triggering preterm birth? Maybe, we don't know. So there are a number of different hypotheses and a number of different pathways. But the short answer is we still don't really understand what is actually going on to trigger these poor outcomes. The WHO put out this sort of draft conceptual framework last year. I'm not going to go through it all because it's a lot of writing there. And they do list in the sort of direct impacts sort of box in the middle there some of these things I've mentioned and also a few others. But I think importantly, they also highlight that it could be these things are happening through indirect effects. So remember I was talking about, changes in access to healthcare. Maybe, people are not, sort of can't be bothered to go along to their appointment, or they can't because it's just way too hot outside, or maybe there's something else going on, or maybe there are sort of stresses on the health system that's dealing with other sort of emergencies, and pregnant women are being deprioritized and poor outcomes happen. Essentially, we still don't know. So this is also a conceptual framework, but you can see it's quite a complicated picture. So doing research in this space is certainly not straightforward. So what I'm going to talk about now is some of the research that we're doing in this space. So the Heat in Pregnancy India project, which, as was mentioned, has been generously funded by the Wellcome Trust. It's a 5-year project. And Wellcome, for those of you who are funded by Wellcome or have looked at Wellcome, you'll know that one of their focus areas is around climate change and health. So they had a call a couple of years ago for projects trying to really understand, this biological and physiological mechanistic effects of what's happening during extreme heat to mothers and their babies. And they funded 10 groups. We were one of the groups that were funded through this call. And essentially our project, whilst it's very big, you can boil it down to we're trying to see if we can answer 4 key questions. So the first question is basically who is most vulnerable to these adverse effects during heat waves? Clearly, in a country like India that has 25 million births a year, there's still a lot of babies born, even though it's very hot, and most of them seem pretty okay and pretty fine, but some of them are not. So how do we identify who is most at risk? Are there epidemiological factors? Are there biochemical factors? Are there other biomarkers that we could look for? The second question we're trying to ask is, well, is there actually evidence that babies in utero are showing signs of stress? Like when it's hot outside, like does the mum's, core body temperature have to go up a certain degree? And so we're looking at this at a really big sort of population level, and I'll talk about exactly what we're doing there in another slide. And then thirdly, what exactly is going on? Like how are mums maybe adapting to heat? How are they maladapting to heat? How is it affecting the baby throughout pregnancy and the lactation period? And then finally, as I mentioned, that sort of key question of, well, so what? What can we do about it? And what should we be recommending to policymakers and also implementing in our clinical practice? So the first question that I mentioned, who is most vulnerable to heat? And the way we are approaching that question is working with colleagues from the Translational Health Science and Technology Institute of India, which is based just outside Delhi, a large, highly phenotyped cohort study, which they've been running for, I think, around 8 years now. And they have 14,000 mother-baby pairs within this big cohort. And they've followed them, in really great detail throughout their pregnancy and up to 2 years after birth, including neurodevelopmental assessments, because another big question is a bit, well, what's the longer term effects on the babies that are happening? And we can start to look at that through this cohort. And importantly, we know where all the mums lived throughout their pregnancy, and working with colleagues at IIT Delhi, which is the Indian Institute of Technology in Delhi, in their atmospheric sciences department, they're able to sort of map these climate conditions and, importantly, air pollution, because anyone who's been to Delhi will know that, this is not a single exposure problem that people living there will be experiencing, throughout pregnancy. And certainly there has been a growing body of work on air pollution and some of these exact same outcomes we're looking at, and we know there's associations there. So to date, the sort of scientific community and climate community, basically, if you go to a conference, there's a session on air pollution and there's a session on heat, and those communities don't really talk together. But what's it like actually for the mom and the baby who are at the center of it, who are being exposed to both? Is it worse? Does one, knock out the other? What's happening? So we'll be looking at that interaction. And because we have a lot of information on these mums, we can look for other potential confounding and mediating pathways, including some of those indirect pathways I mentioned before. And we also have a lot of stored biospecimens, so we can, look for maybe some target biomarkers within that work. And I'm going to sort of draw very much on very preliminary findings that are coming out of that cohort to share with you today, the sort of where we've started and what we're looking at. So Shri is a PhD student in Delhi and is been leading this work with another researcher called Ayushi, who's a biostatistician at TSHTI. And they've been starting to look at, is there an association in their cohort with temperature, with temperature in terms of looking at preterm birth as a first outcome. So I'm going to share some, as I say, unpublished, but presented at a previous conference work from their group. So the exposures they were looking at was, for this analysis, weekly average ambient temperature, assessed from satellite data. So again, not individually measured, but, that's what we have. Preterm birth, and then this concept of lag. So what time lag is getting towards is, well, does it matter if the heat wave is today, that you'll have your baby preterm today, or what if you're exposed 2 weeks ago? Does that trigger off a cascade of events that then lead to you being more likely to deliver early? And as I mentioned, we do have to think in research and in epidemiology about, well, what else could be causing this? What confounders are there? Are there unmeasured things or measured things that we should be taking account of? And for anyone who's done epi, this is what's called a DAG diagram, or directed acyclic graph. And what it is a way to visually sort of try and work out in our heads what is logical links and how do things link up together. And I again won't go through this in detail here, but just to show that we are thinking about, how is this quite complex picture going to play out between this exposure of heat and the outcome we're looking at. So when they looked at the first sort of just over 3,000 babies and mums within the Garbini cohort, what they looked at is weekly average heat exposure and the risk of preterm birth. And this is a bit of a slightly confusing, visual to look at, because it's got 3 axes. And I'll just sort of tell you that, what we're essentially looking at. I don't know if this point away, so it does. So we're looking at, along the x-axis here is the sort of mean temperature for the week. On this axis here, it's the lag, so it's the number of weeks before the actual birth. And on the y-axis is the relative risk. And for India, the sort of mean average ambient sort of comfortable temperature is considered 24 degrees. So this was our baseline relative risk of 1. So when we then look to see what if the average temperature was 30 degrees, which, would be quite hot for all of us in the room here, I think, if it was, but pretty normal for Delhi and people living in India. What they found is actually, if we look sort of 2 weeks before the delivery, the risk of preterm birth went up about 26%. So risk ratio of 1.226 there. If we went to sort of more extreme, if it was 37 degrees, which you might think, oh, that never happens, that it would be that hot for a week, but it does. You know, they've had some very severe heat waves over the last, few years in India. We see that risk, really shoots up to sort of over double of preterm birth. And interestingly, that's a risk, for people in their early second trimester was the sort of lag when that was greatest. So this is early work, it's unpublished as yet, and we still have to validate it in the rest of the cohort. But I just wanted to give you a flavor of some of the things we're starting to look at. Okay, so the second question, as I said, is there evidence that in utero babies are getting stressed, if you like? And how do we measure stress in utero? Well, the obstetricians in the room will know that probably one of the most common things we do is actually measure the fetal heart rate. So we can do other fancy things with Doppler blood flow studies and things, which we will be doing in some of our other work. But what we also know is that the fetal heart rate is a very sensitive indicator of both brain function and heart function in the baby. And we know that, if the baby's brain is starved of oxygen or there are other stresses going on, there will be changes in the fetal heart rate accordingly. And so working with a colleague in India called Shantanu Pathak, who's an engineer, and he's sort of set up this company called Care Mother, which has invented a very low-cost portable CTG, digital CTG machine, which has been kind of rolled out across India. So this map of India with all the dots, this is where their machines are being used at the moment. So it's pretty much everywhere, from up in the Himalayas to right down at the tip of India. What they have is they actually have access to all the digital CTG recordings that are time-stamped and geolocated as to when they've been done. And for some of them, we have, outcome. Most of them we don't. So this is really looking at very ecological level. But what we're doing is working with the fetal monitoring group in Oxford, and Gabriel Jones is there, and we've got a PhD student, Julie Abraham, who are going to be looking at what we call the Dawes-Redman criteria across the board and seeing whether there are any changes with those temperature fluctuations that happen. So all the studies that have looked at fetal heart rate and heat before have been pretty small scale. I think it's fair to say 20 is probably a big number in those studies. If you're lucky, you get to 50 or 100. I mean, this is really pretty massive if we've got sort of more than 300,000 readings at the moment. So the risk always in epidemiology when you have massive sample sizes that you're going to find associations just because it's so big. So we do have to think very carefully about how we structure the analysis here. And at the moment, we're in the process of sort of cleaning the data and matching it up with that climate data across India, which is no small feat, you can imagine. Great. And then the third thing that we're looking at is trying to understand really, what are some of those biological and physiological changes which are happening throughout pregnancy. And the way we're doing this is a multi-center prospective cohort study of heat exposure in pregnancy. So we're doing it in 3 sites in India, which have been chosen because they represent 3 quite different climate zones. So we're doing it up in the north in Haryana, which is at the Gurugram Civil Hospital, which is where the Garbini cohort is also located. And because anyone who's been to the north of India will know they have can have very, very hot summers, but quite cold winters, actually, down to single figures. So a real climate variation, but quite high air pollution as well, particularly in the winter months. We're then also working in a place called Bilaspur in a state called Chhattisgarh, which is the sort of red blob in the middle of India here. And Chhattisgarh is a state which has some of the highest temperatures recorded in India in the summertime, but the winters tend to be quite wet and not quite so cold. And then finally, we're down in Pondicherry, or Puducherry, as it's now being called, which is a coastal, tiny little union territory in India, where they don't have the extremes of temperature, but they do have big changes in humidity, which, as I say, is another key component to look at. So this is why we're working in these sites. The idea is we're going to have 200 women in each site, and at each site, half the women will be recruited in their coolest months and half the women recruited in their hottest months. So we should have a summer cohort and a winter cohort moving through, and we're going to measure a lot of different individual heat exposures and maternal fetal placental assessments through each trimester and lactation. And the cohort profile's just been published in Wellcome Open, so it is available if anyone's interested. And so as I say, you know, the exposure assessment is crucial here, because this is really moving away from that ecological sort of, you know, picture, which is what most research has been in this field, to really trying to nut out who actually got exposed to heat and who responded badly or well to that exposure through their physiological adaptation. So working again with Vidya and Rekha's team, and now Tanya's joined the team as well, we have a really you know, detailed microclimate exposure each trimester in the woman's home or her workplace for 24 hours. And we're also collecting, as I say, physiological heat strain indicators. So what do I mean by that? Well, physiological heat strain can be measured through, I guess, changes in heart rate and blood pressure, which we're collecting, changes in core body temperature. And the best way to do that is actually with one of these pill thermometers to capture, you know, core temperature through the gut. That was not going to be feasible in the study we're doing, just given the logistics of where the study is being conducted. So we're actually using a ear canal monitor, which has been validated before. And we're also looking at urine-specific gravity, because you can imagine dehydration is going to, you know, definitely be an indicator that you may not be adapting well to the heat. So this is happening throughout the pregnancy, and you can see sort of a fancy sort of Fitbit type device, we call an iButton, that measures not just heartbeat and activity, but it also will collect skin temperature and you know, temperature on, you know, that your wrist is exposed to in the room, and humidity there. So a lot of data coming in. And then at each trimester, we've got a very detailed protocol for how we are assessing the women, the baby, the placenta throughout the pregnancy. So working with Baski, who many of you will know, who's very, very well known in the field of maternal hemodynamics, working with him to use the USCOM machine, which measures a wide number of, large number of parameters. I think about 65 parameters or something quite crazy, you know, about circulation from a non-invasive measurement. We're then working with Aris, who is at St. George's and Oxford, so many of you will know Aris Papageorgiou, and Ashok Khurana, who's a leading fetal medicine specialist in Delhi, to have a very standardized and quality assessed and controlled protocol for how we're measuring the growth of the baby, but also how we're measuring some of the Doppler indices, which would, you know, perhaps indicate redistribution of blood in the baby or problems with the placenta. Now, of course, not all these problems, that if we pick up problems, are going to be due to heat. You know, there could be just all the usual stuff that's going on. So we're collecting, of course, a lot of other information about what's happening in the pregnancy at the same time. And for the third trimester, we'll also, of course, do a CTG using Shantanu's device. And then, you know, we're very lucky to be working with, you know, some leading placental biologists to really help us try and think, what are we going to look for in blood that might be indicating placental stress or stress on the fetus. So Manu Vatish, many of you may know, so Manu's a obstetrician and placental biologist in Oxford, and also with the Gates Foundation now. And Pallavi is you know, a biologist based in Delhi, and we've got a PhD student. There's another PhD student in Delhi I haven't got a picture of there, but a good team working. And what are we going to be actually looking for there? Well, that's a good question, because, you know, where do you start with this? We don't really have a lot of animal data or even you know, in a sort of vitro data to really guide us here. So what we're going to do is, in the Garbini cohort, where we've got the stored samples, do sort of a case control analysis looking at women who had normal outcomes and poor outcomes based on seasonality there. So that hopefully will give us some sort of, you know, putative markers, which we can then either, you know, retest or validate in our prospective cohort. But we're also going to be looking at, you know, syncytio, trophoblast, circulating extracellular vesicles, which for the non-placental people in the room basically are like sort of very micro placental biopsies, which are circulating around in the woman's circulation when she's pregnant. And we can you know, isolate them, and then we can look to see what's in their cargo. So in terms of it could be transcriptomics or genetics and other markers. So, so some exciting work here, but I think, you know, as I say, really starting from, you know, quite a sort of hypothetical and new base. We are going to be doing some in vitro biomarker discovery work in Oxford with some placental explants here, sort of heating them up at different temperatures to see what sort of changes maybe in the cargo of the circulating extracellular vesicles they are. And that's Manu's lab are going to be leading that work. And then finally, the last part, but not the least, is looking at lactation. So when I started this project, I was pretty shocked to find out that when you do a PubMed search on lactation and heat, everything that comes up is about cows, basically. It's about dairy cows. There's almost zero. Maybe I think there was one study done about 30 years ago in Africa that was sort of just, wasn't that sophisticated at the time because of the technologies that are available, but really there's very little. So again, we're fortunate to be working with Fadil, who is a professor of lactational endocrinology in Oxford, as well as Dr. Shalja, who's in the Delhi TSHTI, to really try and see whether we can see changes in the timing of lactation onset, the composition of milk. So, not just thinking about sort of lipids and proteins, but also looking at maybe, other factors, transcriptomics and things that we can measure in milk, and also changes in serum prolactin, which are, pretty essential in terms of establishing and maintaining lactation there. So I think this will be a really exciting part of the project. And I think, Wellcome have also sort of latched on that this is a very neglected area. And that certainly Alan Dangar and people are talking about perhaps having some more themed funding in this area. So for the researchers out there, keep a lookout for that, because I think it is essential. And if we think about how important breast milk is, for nutrition globally, this is a big issue. So where are we so far in this project? So we started almost about a year ago exactly. And it took us, it's fair to say, the first probably 6 months to get all our ethical approvals and documents and protocols and SOPs and everything in place. And for anyone who's done multi-center research in a place like India, you'll sort of agree, well, that seems pretty fair, that it is a lot of work to do that. So it's a big team effort. We've also completed training and standardization of the staff across the sites and have about 150 women recruited to date, and about 30 of them have delivered. So we're gearing up to start our winter recruitment, which will commence in November. And the hope is that we will finish in early 2027. So, watch this space. The photo there is from our, we had a retreat in early July in Chhattisgarh. So some of the team, well, probably about 2/3 of the team were there. You can see. And you can see from the picture I've put down the bottom here, I took this on one of the visits to the hospital. This is just to give you an idea of how many sort of, things need to be done at each visit, the hospital visit, the home visit, on each participant. So, there's a huge amount of data being generated, from this project, which, I think we're only going to probably scratch the surface in what we're going to be able to analyze. So any students and things out there, this is a really great project to get involved in. Good. Okay, so moving on to the final part of the talk, and that's probably the most important thing, as I say, and that is actually, what do we do about it? And what's the evidence that we can actually do something to protect pregnant women and babies? So if we did find that there's this particular group who are particularly vulnerable, what would you say to them, and what would you do? And our approach to this part of the work, which is also part of the Heat in the Pregnancy project, has been really to go in with our ears and eyes open and listen and understand what are the actual challenges that women and their families are facing, during extreme heat events in India. So we're really focusing on the participants in our study, listening to their stories. And what we particularly want to do is really learn also from Indigenous knowledge. I mean, India has always been a hot country. It's not like this is suddenly struck. It just seems to be getting hotter for longer. And the temperature extremes are getting worse. So what are some good practices we could, help, to spread to other areas? Also, what are some maybe less good practices that maybe need, some public health messaging to be dialed back? And then we're also sort of looking at the moment as to, what are the policies and things in place? Do they consider pregnant women, lactating women, babies at the moment? And then finally, we're hoping to move to sort of a co-development of an intervention stage and implement this. And as I say, because we are still at the earliest half of our work, we are still at the first, 3 points here. So watch this space for the third one. So I'll give you just from 2 of our sites, some of the early insights that are coming out from that listening piece, which I think is really interesting to actually hear what is it like to be pregnant, you know, when you're living in India and you don't have any access to cooling. And the first place where we have really looked at this in depth is the Gurugram population. So we're working in a government hospital there. So the women who access the government hospitals are mostly from sort of lower income groups living around Gurugram. So Gurugram is, it's been sold as sort of a tale of two cities. So it has a very shiny, flashy private real estate development side, and around that sort of luxury gated communities with densely packed informal settlements that lack basic facilities and water. So you can see from the picture there sort of examples of the housing from, that the women in our study are living in. And this work, as I say, has been led by, Chris and Karthika and colleagues from the George Institute in India. And so we conducted, first of all, a roundtable with some of the sort of important stakeholders, to that listening event, what is going on here? And so we got key insights from practitioners, planners and health experts in the area. And that sort of dual urban reality really came out and sort of fragmented governance also. And I think what also is very important here is the people who are living in the informal settlements are largely a migrant population. And a lot of these people really have very little social connection and connectivity with their communities. There's not great NGOs we've found in that area that are really looking out for women's rights and things, because it's just very sort of transient and fragmented as people come in. They come in to work on a building site and then they go off somewhere else, afterwards. So it's hard to get that, I guess, momentum going. It's also, noted that there are quite stark gendered vulnerabilities to heat, and women often, if they're not working, are expected to be inside the house, and often it's not considered safe just to go walking about or wandering about. So there's mobility restrictions. And if they are working, they might be working on a sort of building site informally, and there's really no protections in place for during pregnancy. And they also noted there's a lack of data, which is probably pretty common across many sites. And you can see here, that in the sort of pinker box there, some of the other themes coming out about, the hospital seeing a rise in cases of heat signs and symptoms in pregnant women, but the systems still remain fragmented. They're not really capturing the data. The other thing they noted, which I think we really do need to think about when we think about interventions, is this idea of sort of indoor heat being sort of a hidden threat. So in India, sometimes, if there is a heat wave, the advice might be, well, stay home. It's too hot to go out. But if your home is a concrete box with a tin roof with no ventilation and no windows, you may actually just be cooking yourself, sitting in that home. So really making sure that messaging is appropriate, and, dealing with issues around water security, physical burdens, and, policies are currently pretty blind in locally there about issues that pregnant women may face. So, some good insights there. We've also been doing some, in-depth interviews with the women in the study, and there's sort of an ongoing qualitative piece of work here. In the interest of time, I'm not going to go through all these quotes and things, but just to highlight, you can see in the blue italics some of the sort of translated stories from the women themselves. And, the second one, the house is small, everything is in one place, cooking, sleeping, everything. I sleep here after doing all the work, though it's hot. And, the fan doesn't do anything properly, then I sleep on the roof at night. So it's just hearing these narratives from women, I think, is always so important when we're doing research, rather than just focusing on, let's find a new biomarker for heat exposure. This is probably actually what's driving a lot of the poor outcomes. And then, other themes to come out, supporting things around, the gendered mobility, changes in their sort of social role. Now they're out of their village, they're out of their community, and they're sort of a bit isolated, not having a support system, and then not getting sort of much support from the state either, not really linking in with free systems such as community health workers, primary healthcare, which the government of India have made available to all pregnant women, but they're not sort of taking advantage of these things. So important things coming out. The second site where we've done this so far, we've only done it in 2 sites, is in the Chhattisgarh site. And again, we're working in a government hospital there, working with mostly women who are living in informal settlements or slums. Chhattisgarh or Bilaspur is an interesting place. It's also got quite a high migrant population, but it has quite a high proportion of women from what are called scheduled caste and tribal women. So these are some of the more marginalized groups in Indian society, sort of historically, but also contemporaneously as well. You can see in Bilaspur itself, you know, a third of the population live in these informal settlements, and you can see some examples here. You know, they don't have running water. Sometimes they don't have doors. They don't have, you know, proper roofs or privacy, these sort of things. And we did a roundtable also in Bilaspur, and similar sort of themes came out to a large extent, which is not entirely surprising, but there were a few, you know, sort of, I guess, eyebrow raising, you know, things that came out through the discussions, particularly around gender-based violence here. So this was something that this group did discuss. And it's not an uncommon thing that women actually, you know, as well as, you know, being victims of physical violence, are victims of abandonment in pregnancy. And this leaves them extremely vulnerable, you know, with very little way to support themselves, support their, you know, child, and particularly if they're migrant, you know, from other places, they may not have social support. So, you know, this was really quite sobering, I think, for the team to be hearing these stories. But, you know, the Bilaspur group also, you know, tried to come up with some positive messaging about, well, where could we sort of start to do some positive change here? And one I thought was quite interesting around sort of food provision. So remember I said we were thinking about indigenous knowledge, and in this area of India they have sort of traditional foods that they may think of as cooling foods, which could be provided through some of the government food supplementation programs that are listed there on the screen. Please don't ask me about what examples of cooling foods are. I really can't remember at this point in time, but there are different, I know sort of in the south of India, they often have coconut water and things. I can't remember specifically for Bilaspur, so I'll have to get back to anyone who wants to know about that. But also other, you know, important things that could be useful: resting sheds, mist cooling systems, access to clean toilets. Now, this is a big thing in the workplace, that women will dehydrate themselves because there's nowhere that you can go to the toilet in a private way, in a safe way. So that could be really making things a lot worse. So access to drinking water, and then thinking about early warning systems and awareness, and what can we do in that space. So, and the final thing I wanted to sort of mention just in the last couple of minutes, sorry, you're probably not asleep yet, is some of the, you know, thinking about, you know, well, where do these sort of interventions fit within what already exists in India? And is it an issue that there is a policy, but it's just not being done, or there's just not a policy at all? I guess they're the questions we want to look at. And India is actually one country that has a lot of heat action plans and state action plans on climate change. In fact, probably more than any other country around, because there's been a big push from the government to really have you know, be prepared here. But there is limited analysis on how these plans are addressing the specific needs of pregnant women and their babies. So Gabby, who's a doctor from Peru and a research assistant with me at Imperial, has been leading the group looking at this work. And so what the group have done is they sort of obviously identified all these plans, and then they've done a sort of desk review and tried to classify, you know, are pregnant women included or not, yay or nay? And then if they are, what sort of interventions are actually included? And, you know, we've looked across behavioural change interventions. So this might be telling people to take rest and stay hydrated, stay in the shade. Health system and service interventions. So this might be something directed at, you know, planning in health systems as to, you know, maybe you should have your clinics, you know, in the cooler hours of the day or something like that. The built environment cooling and nature-based solutions, so planting more trees, putting in more aircon, particularly in maternity units or cooling systems, and then structural policy and climate financing interventions that target women particularly. What they have found when they looked at these results is, of the 35 plans identified, a third of them had no mention and no consideration of pregnant women, lactating women, or babies at all. So these are represented by the states that are in the sort of palest pink on the map here. But it's not all bad news. There was actually some pretty good practice going on. And actually, you know, when we look at the other plans, there were actually 214 different strategies which mentioned women going through. So it's not like this is not known. This is on the radar. and 102 of them were unique strategies. So you can imagine sometimes the same strategy might be mentioned in different documents or in the same document different times. And the sort of things that they looked at in the strategies were mostly around that behavioural change bucket, which is not surprising, because that's like what we get told, isn't it, in the UK? If there's a heat wave coming, you know, stay cool, stay hydrated, you know, don't go out in the middle of the day, those sort of messaging. So that was the most common thing that happened. But it was interesting to see also there were, you know, a number of recommendations around setting up policy, a number around providing better access and communication and prioritization within the health system. And then finally, the sort of built environment, maybe the fewest number of recommendations here, but a few there around, you know, providing more space and cooling, you know, collaborating and providing more access. So as I say, a bit of a mixed bag. So I think there's some good examples, but there's also some, you know, the states that, you know, haven't even got this on their radar yet. So next steps for this work we're doing. So as you can see, it is very much work in progress. I've been presenting to you all this evening, so I hope you respect that. But I think, you know, I hope I've given a bit of a flavour as to the breadth of what we're looking at, you know, right from molecular stuff to health policy. So it's a pretty big program of work. So we need to obviously complete the, obviously the prospective study is ongoing, but for this work, we need to complete our community engagement work across all 3 sites. And then we're going to move to these sort of co-design workshops in each study site to try and develop contextually appropriate and affordable heat adaptation solutions for protecting pregnant women. And the idea will then be to test and scale this, but it will be a little bit funding dependent. So you know, any funders out there listening, you know, please, you know, do come and let me know. So, so that sort of brings me to the end of what I wanted to say to you all this evening. And I just had a couple of take-home messages for you. If you've fallen asleep, you can wake up again now. So the conclusion is the world is getting hotter and extreme heat is threatening hard-fought gains in maternal and newborn health globally. So if you think about where some of those hottest countries are, this is still where certainly our maternal mortality and newborn mortality, you know, we've made great progress, but things have seemed to have stalled a little bit, probably not just for climate, but we risk going backwards. And the associations that we are pretty confident are there are around preterm birth, stillbirth, preeclampsia, gestational diabetes, and some other complications such as congenital abnormalities. But we really need more evidence to understand this, the mechanistic pathways by which this is leading to poor outcomes, and critically, how heat is interacting with other risk factors, social risk factors, healthcare access factors, other environmental factors such as air pollution, because we really don't have the full picture yet. And I think implementing contextually appropriate adaptation strategies to protect pregnant women should be a priority, but we need evidence to guide this. So when I'm showing you the policy landscape in India, it's very encouraging that there are a lot of recommendations, but most of these are sort of common sense stuff. Like there aren't any randomized trials in this area. There's, you know, really more, you know, urgently needs to be done. So I'm going to stop there. I've got sort of a list of, you know, some of the team, I think probably about 80% of the team on the screen here. Sorry if anyone's listening online and I've missed you off. You can see this is a huge team effort that we're working on. And yeah, I look forward to hopefully sharing results, you know, in the next few years as they emerge. Thank you.
Okay, thank you very much. So we have time for a couple of questions. We've got some drinks outside if you're gasping, but does anybody have any questions? Owen, shall we see if we can get that one? That one?
Oh, thank you.
Usually, biological samples.
Yes, thank you. Two very, very good questions. So for the first question, more sort of classic markers of stress like cortisol and things. Yes, we have considered that, and we will look at that. Although I think cortisol itself, the assay, there are some issues around doing that properly on stored samples. I'm not a biochemist, but we have been talking with people, so we can look at that. But we are going to be looking also at some of the sort of classic sort of placental markers. We're now used to looking at like PLGF and S-split and the angiogenic sort of biomarkers that we use for preeclampsia and things also. So I think that is a work in progress. And there is actually a group in Cambridge who are also looking at this through the Gambia grant that they've got. So I think coming together and trying to nut out a sensible approach to this would be worthwhile. And then for the second question, yes, of course, we're looking at very different populations. It's basically, India is like, it's like comparing Europe, sort of, if we took someone from Norway and compared them to someone in Sicily or something, there's so many differences. And it's the same when we look at the north of India and the south of India. So dietary changes, genetic differences, behavioral differences. So we are trying as far as we possibly can to capture some of those things. So for example, we've got a food frequency questionnaire, which we have, sort of one for the South Indian site and then for the North Indian sites, capture that as much as possible, as well as sort of looking at, some of the more sort of behavioral things. The big difference that we're actually struggling with is that the South is actually a lot more prosperous than the North. So our Pondicherry site, one of our exclusion criteria is to be part of this study was you don't have aircon at home. And so we keep recruiting people and then they keep buying aircon units sort of at home because it's really hot. So that's one of the things that people want to go out, and you can't stop people wanting to make their lives a bit more comfortable. So I think, we're going to have to think quite carefully about how, whether we present them as a stratified thing, as 3 separate sites, or whether we have enough commonality that we can pull those results. But I think that's something as a scientific committee we need to look at, but they are quite different. So
I wanted to ask a little bit about how you might control for the effect of the fact that a lot of these hospitals in which you're recruiting the women and examining them are probably, do they have aircon? I mean, are they going to be the same temperature? Because we know just from labor ward when a woman's hot, if you just do some, paracetamol or whatever, quickly the temperature comes down, the fetal heart rate goes down, and it's quite it's such a sensitive measure. So are the hospitals as hot as the women? Okay.
Yes, no, good question. So that was one of the reasons for working in the government hospitals, and I can tell you they don't have air conditioning from having been there. But the one room where we have found it's important to have air conditioning or the machine just sort of doesn't work is, of course, ultrasound. So the ultrasound machine will overheat if it's 40 degrees and just won't work. So there has to be, a little bit of give and take there. So they will be whilst they're having their scan in a climate controlled room. But we have tried to sort of have some, sort of data loggers and monitors to try and keep an eye on what the temperature is in the hospital environment, because it is a big factor. And that could actually be one of our recommendations, that, there should be more cooling, within maternity units. But at the moment, I think there's not really evidence beyond that. Seems like a nice thing to do. I mean, I know in Oxford, we don't have any air conditioning on our delivery suite, and it gets pretty damn hot, during summer, which I'm sure other people in NHS trusts will have experienced as well. So yeah, I think this is something we all need to be kind of thinking about.
Thank you for amazing talk. I wonder about the extent to which your findings are stimulating discussions about cutting emissions in India and other high emitting countries, because the focus on adaptation can of course be very empowering for women and their families and local governments, but it's also the playbook of the fossil fuel industry, which is to shift responsibility for adaptation, externalize the risk onto individuals and local governments. But if you're seeing those big increases in preterm birth, and preterm birth, of course, has extreme human costs and economic costs, is there value in looking at those costs in the long term to strengthen the case for reductions in emissions, or just focusing on adaptation?
Yeah, no, thank you very much for the question. I think that's really critical and super important. And of course, I haven't really been speaking about the role of mitigation and emission reduction at all in this work, but it is critical. And I think, I started with that slide of Antonio Guterres, and his heat action plan largely focuses on the need for urgent mitigation actions. And, I think we're all sort of aware the world we're living in at the moment, it's looking pretty dire on that front with what Trump is doing, what other governments are just like, well, Paris, schmaris, we'll just sort of, move on and keep burning fossil fuels. And I think in India, being an emerging economy, wanting to grow their industries, it is a massive problem, there. And I think particularly around the air pollution issue, which, I mean, they may not be seeing the direct link with heat yet, but they probably are. They're just trying not to, I can't speak for the government of India, how they look at that, but air pollution is a massive problem there. And, I was in Delhi last November, and the air quality index was like 1,000 or something, and safe is meant to be less than 20. I mean, it's just, this is what people are living in, breathing in, playing and working in all day. So I think that does need to be addressed. I guess, I think, even if we stopped burning all fossil fuels right now, I think the scientific consensus is we're still on this warming track. The oceans are warming. There's no way we can slow that down. So I think we do need to be thinking about adaptation still. And I guess that's where our group has sort of focused more of the efforts, but it's not to take away from what you're saying. And Anna and I were just talking before actually about what can we do as individuals to try and minimize our own carbon footprint. And I feel particularly guilty because as a professor of global women's health, it kind of has involved a fair bit of travel since I took on that role. And I'm very mindful of the fact that every time I get on a plane to India, it is contributing to the problem. But hopefully in a small way I could try and contribute to a different solution, but it is something that I think we all need to be quite mindful of. So,
Great. Yeah, question for that. Yeah, we were talking about EVs, solar panels, drying outside in the garden, all of that stuff, not using plastic.
exactly. Yeah, so.
Thank you so much for that wonderful talk. I have been honestly following your work for quite some time, and I'm very impressed by it. So I was very happy that I got a chance to attend this talk. 2 questions. The first one might be a little sensitive. It's just that you mentioned you're looking at a lot of different criteria that kind of has an impact on women during their pregnancy. But has female feticide been one of the criteria that you consider? Because I am from the south of India. It's not a very common practice. In fact, it's not a common practice at all in the south of India, I can say. But it is common in the north of India. So was that one of the factors that you considered? Like, will female feticide be an issue? Will that have an impact on the women, on the family and stuff? The next question is, of course, there's a lot of, the sample size is quite big. So have you, I mean, as part of the study, involving ASHA health workers, who are the maternal support workers from India, has that been one of the criteria used to get the support, basically like to increase participation of women in the study? Yeah.
Yeah, no, thank you very much for those questions. So for the first question around the female feticide and infanticide, it is sadly still a reality that whilst it has been illegal for a number of years in India, it's illegal to tell the sex of a baby on ultrasound. As it still is a practice that people tend to find loopholes or ways to get around that. I guess we are offering ultrasound scans by participation in the study, at a very high level. And of course, our scanners would follow the rules of the government of India. If people are going off sort of privately or wherever, we can't stop that. But we will be able to see at the end of the study whether the sex ratio at birth is skewed or not. Where I've been working in another part of Haryana, which is in the same state, this is a big problem. I haven't heard it being such a problem in Gurugram probably because it's a very migrant population and things that maybe it's drawing in from people who have and don't have that tradition or that culture. I can't really comment to it too much, but it will be something we will be able to look out for there. And then the second question, remind me, sorry.
It was about the involvement of ASHA health workers.
Yes. Yes, so they are pretty critical to this because you raise a good point that, when we first started this study, the Garbini study's been going for years, and they do all these good assessments and scans and blood tests, and they're like, yes, we know how to do this. What they weren't so familiar with actually going into people's homes, setting up these monitoring devices, leaving this strange looking thing in your house for 24 hours. And you can imagine it doesn't take much for there to be a bit of gossip around or a bit of suspicion. And what actually happened was, the stories which we've been told is a lot of these sort of slum areas, they're sort of controlled by landlords, like they all pay rent and things to be there. And the landlords were actually getting suspicious of these devices, that it was some sort of government device to sort of, capture how many people were there and how much tax he should be paying or something like that. Like people sort of just take it off into really weird directions. So involving the community health workers is really critical. And it is something that, we have done to be able to help recruitment, help sustain people, within, help reassure families and communities that we're not out to hurt them, or there's no radiation from these things. They're not going to, it's very easy, when people are faced with unfamiliar things, that they think it's, a threat in some way. So yeah, very important.
Thank you so much.
Yeah.
Jane, thank you so much. It was absolutely fantastic. I think we will call it an evening there, just to say thank you for a fantastic talk. It really makes you think about, how fortunate we are to live in the UK, but also that we are really struggling with this, and it's going to have big impacts on outcomes worldwide. Thank you so much for your time, and please join in thanking Jane.